Okay, so thank you very much. So I think when you investigate an outbreak, I just want to mention that you have to remember these 10 points which I'm going to highlight. In every outbreak, in some outbreak, you may just finish at only one or second point, but you have to remember all these points, which I'm going to summarize, and you have to remember that from start. So the first question, I think, what's the definition of an outbreak? None of you actually got it right, on the first day when we asked this question. So the concept of two or more related cases is really very dated concept and definition of outbreak. I have no doubt at this moment of time, lots of trust within the province and the United Kingdom have got two or more related cases of C. diff or MRSA and things like that. That does not constitute an outbreak. So you can see the definition is an increase in occurrence of cases of disease above the usual expected frequency within the specified geographical area or season over a defined period of time. So you can see there is a huge range of stuff involved in terms of your decision making in that process, whether you call it an outbreak or not. However, if you actually find single case or something which is very unusual, which you have never seen it before, like case of Ebola or diphtheria, right? Or case of polio, for example, that actually constitute an outbreak. And these are all the WHO definition. And this is what we apply consistently throughout the whole region. But you can see that WHO we use slightly more definition in terms of broaden the whole thing. So this is definition of outbreak. So you can see the first one in which we have MRSA. Remember, we highlighted that we have no MRSA in the neonatal unit for 18 months. And then you got one, would you classify that as an outbreak? And you see the gray area, isn't it? But on this one, we are very clear. This is really unusual, unexpected disease, which you have never, ever seen it in this region at all. People used to call it incident, or you can call it outbreak. It doesn't even matter, but I think it is. So first, I think this is very important. Be aware of pseudo-outbreak. Ascertain confirm the reliability, not only the clinical ground, but also laboratory information. And I've highlighted example that we received a swab from MRSA from an amputee, and the patient met me in the corridor. Okay, so the whole idea was that somebody put a wrong sticker. And Martin highlighted other issue in which the patient didn't have C. diff, and somebody filled in the wrong form. So I think this is very important. And so you have to go back to the patient to actually make sure that this doesn't happen. Now in laboratory, our workload is approximately 1.8 million. And the error rate, expected error rate, about 1 to 3%. Okay, so you can see the number of patients we transferred in which we misdiagnosed diabetes, for example, MRSA and all bits and pieces, really phenomenal. So the risk we run is very high, and we highlight people to actually fill in the laboratory form properly. It's a challenging task, and I can tell you as a clinical director, it was a really challenging task. Second thing, you have to confirm the reliability. And then you look at the changes, what had affected it. And it was very clear in the case study, which we did 2 days ago, that there was a lot of pressure in terms of admission of the staff, right? People with neonates in the neonatal unit. And the second issue was they were short of nursing staff as well. The other issue is that even you confirm that this outbreak is not really an outbreak, you must go back to the clinical team to reassure them that this is not an outbreak, okay? Most of these outbreaks happened on Christmas Eve or long bank holiday weekend at 4:30 on Friday, okay? So it's because this is the area, what actually happened, and sometimes you ask why you did not inform me about 3 days ago. Because they're all panicking, on Friday. This is the reason. They're just going, what I mean, just want to make sure everything is okay. That's the reason behind it. So if you look at pseudo-outbreak, first we look at the laboratory factor. Introduction of new test, I think we talked about that, it could have poor sensitivity specificity. And remember what we talked about? Clostridium difficile. It took 5 years in Northern Ireland to actually agree what test we do for C. diff. Okay, so now we are consistent. But before that, the number, people were arguing, which test you do it. So I think there's an issue. Remember, there's no test in the laboratory which is 100% sensitive or 100% specific. So you always have this variation. So suddenly you change the test, either you miss it or you're overdiagnosis. So this is a very common cause of pseudo outbreak. And then you could improve technique for identification because the microbiology is changing all the time. And there are actually new methods available of detection. And also this is quite common, you may not believe it, but contamination of processing. And when I was working in London, we have got outbreak of tuberculosis, which was basically created by a laboratory technician, in which what he was doing, that the first patient was positive, and second and third tube, because he did not use aseptic technique, the 3 other patients were positive. And when I visited the ward, the patients were completely fine. And the other interesting outbreak was outbreak caused by group A streptococcal bacteremia, 4 of them. This was in 1980s when I was working there, and you remember this is a Sony Walkman era. And this guy was actually put his headphone, and while he was actually doing the blood culture, he was talking, and he was contaminated. He has contaminated 4 of the blood culture with group A streptococci, which was in his throat. So when we went back, the patient was completely fine. So there's a paper published, group A streptococcal after seeing bacteremia, something like that. So we have said that. So sometimes these contaminations do actually happen, and when we have a blood culture, we just want to make sure they are done in a separate room, and the person should not be disturbed and should not talk, because we do carry meningo and we do carry group A streptococci in our throat as a normal flora, okay, like Staph aureus. So these things are actually real. And the ward level incorrect diagnosis of clinical entity, because we do not take a proper clinical history. And I think when we talk of Ebola, you must ask. You see, the Northern Ireland is not like exactly identical when I started about 30 years ago. Okay, the dynamics have changed a lot. So you have to ask a travel history of the patient. You must ask. We are traveling more, but we have lots of people who are actually coming from the other part of the world as well. So the whole dynamic have changed. And we have seen a case of sleeping sickness and leprosy and all these sort of things, which I never seen it, but we have seen it. These are unusual cases, but they still happen. Failure to distinguish between community-acquired and healthcare-acquired infection. Now, there's a third term, which is called community onset. And this third term, you have to remember it now, because of the higher throughput of the patient in the hospital, you may not detect infection in the hospital, which we have given, right, because of incubation period. So the patient appeared in the community. Classical example would be surgical site infection. If somebody is admitted for this hospital for surgery, discharged within 24, 48 hours, 3 days later, we got a phone call from GP that the pus is pouring out from the wound. That's basically community onset infection, but actually it's healthcare associated infection. So now this is the third term we are using, and that has to be counted as a part of hospital-acquired infection because we don't follow up. So if you look at the figure, I just tell you a very interesting story. If you look at the surveillance figure, they keep on coming down. Is it because our infection practices are better, or we have appointed more infection control nurses? No. It's because of higher throughput of patient. Okay, before, in 80s when I started, the average length of a stay after cholecystectomy was about 5 days, 4 to 5 days, okay? When my mother had a cholecystectomy, she was there for 9 days, okay? Now it's a day procedure, yeah, isn't it? So I think we have taken into consideration that mislabeling of specimen, I think, is very common, and if you're in doubt, please ask for repeated specimen. And this is the reason that we ask for 3 specimens from the patient with tuberculosis. Why? Because we do not want to really misdiagnose tuberculosis. So there are certain diseases which you are in any doubt, please repeat specimen. So you have to take into consideration the laboratory correlation with the clinical picture. You must do that all the time. And again, the contamination of a specimen, if the correct procedure is not followed, and this actually happens very frequently in the laboratory, especially when you get new staff and people are not trained. The environmental factors include poor microbial quality of water, and there are documented outbreak of tuberculosis from the decontamination of the AR machine, the endoscopic cleaning machine. And if we don't clean it, this is the reason we test water on a regular basis. And they can be contaminated with Microbacterium cheiloni. And there are documented outbreak of endoscope decontamination because people are not looking after the machine very properly. And misdiagnosing, these are very documented cases worldwide. This is the reason we do not use tap water, because at the moment, if I'm actually drinking a glass of water, I may be injecting 1 million bacteria of tuberculosis. And the green stuff you see around your taps, they're all full of Mycobacterium tuberculosis. And I was giving in Southeast Asia and Africa, where we may ingest about 1 billion bacteria in a glass of water, and therefore the BCG does not work in this part of the world. So I think we have to take into consideration all these factors. They are harmless, except the tuberculosis or MTB complex. All microbial specimens must be actually sent in a sterile container. Looks very easy, but I've got a whole section on laboratory where we receive a specimen of urine in a milk carton container, where the people drank the milk and just eat it. A specimen arriving in a jam jar. But this was the most interesting. What actually happened, I was actually coming out of the lab, and this patient came in a shopping bag. So I thought possibly, where's the micro laboratory? So I actually tell this is the micro laboratory. And I thought she's going to submit a urine sample, but basically she bought a warm sample of 1 kilo of stool in a famous shopping bag, completely warm, okay? And the patient got diarrhea. But by this time she settled. Now you can imagine if she didn't have diarrhea, okay, what would happen? But we did it. And this is the 1 kilo of sample which had been sampled by our MLSO in the lab. And I've got loads of pictures to actually tell you lots of a story. But this is just an example that people do not actually send a specimen in the sterile container, so you have to tell them. And sometimes we always complain that people are not actually filling the form. And this is the GP possibly got some information from me, and there he says feces coming site of specimen. So sometimes they actually think that as a microbiology, we have no imagination where these samples are coming from. Okay. Now, this is when I was clinical director over here. This is, you may not believe, all the reports which I've collected over 2 years in which we do not have a sender name. Don't you think so? It's shocking? And some of the money we have paid for the testing of hormone to English laboratory, costing about £300-400 a test. This one, nobody would claim it, that they are their sample. Now you can imagine what happened in micro, that you may have sample from food handler, yeah, and if you cannot trace back to the GP, then it's an issue, in terms of infection control and cross-infection as well. But I remember a very interesting story, because sometimes our secretaries made error in terms of when they are sending the laboratory. And they have to look back, and if it's not their patient, they should send back to me. So I received a urine sample we used to do at that time, the pregnancy test. So I received a return report from a GP saying, Dr. Damani, this is not my patient after 13 years. Okay. So sometimes, I don't know where this form was lying there, but after 13 years, you recall that this is not his patient, So there is a lot of issues with laboratory. So you have to confirm this diagnosis. You do investigation. And once you actually do it, you have to take immediate action. And then you seek advice if you want to actually collect the appropriate specimen. Just think what facility available you have. Yesterday, Martin actually gave a presentation, and I think we are so fortunate in Southern Trust that we have all those tests which I've wanted to fight for a long, long time. We have it available. You have to have this quick diagnosis, I think. Very important. In terms of effective utilization of bed, because you've got less bed, you've got less side ward, but you do not have proper isolation facility. Any side ward without an suite toilet facility is not classified as isolation facility. So you are trying to separate the patient, but you don't have it. I'm sorry to say, but you don't have it. That's what it is. And we'll talk more about it this afternoon. And then, of course, you have to actually take a specimen, ideally, which is very difficult because most of the time patients come, GP and given some antibiotic therapy, virology, and then try to actually utilize the rapid diagnosis of tuberculosis And there's a list of more tests which Martin has shown you yesterday. Try to utilize those as quickly as possible. This is have two implications, not only for IPC, but also for the patient management. That means the patient is on appropriate therapy or not on appropriate therapy. It will help you to minimize the misuse of antibiotic. Once you know it's a viral infection, there's no point giving antibiotic, isn't it? So these are the, or in case of legionellosis, appropriate antibiotic therapy and full investigation. And for virology, we have got excellent reference laboratory, I think one of the best in the world, honestly, that we are very fortunate to have it. And they do, in fact, they develop a lot of primer and lots of stuff, a lot of research goes on, and this is one of the best laboratory. But you have to really tell them what you really want. Most of the time, they don't get information. So there you've got a patient with meningitis, which you suspect is viral, but you don't actually send a throat swab, so how do they will know? Okay? So you have to provide this clinical information. So when you have the patient with infection, just make sure you provide as much clinical information. Screening swabs are actually different than the diagnostic swabs. Virology, you have to provide them the information because they have battery of tests. They can't test everything. We can't test everything. Initially, so third point, I think you have to remember. So once you confirm the diagnosis, the third thing you have to do is to have case definition. What is your case definition? When you're developing initially, you have to throw a very broader net. It's just like catching fish. You want to catch all the fishes, irrespective of the size. And then as you go along, you try to narrow the whole thing down to a bigger fish or a smaller fish, depending what it is. So you try to actually have narrow down. You must classify, very important, you must classify into the cases which are confirmed. That means they have got clinical symptom, plus approved diagnostic test which confirms it. Probable cases, clinical symptom, waiting for diagnosis. And probable cases, or possible cases, it's a contact or anything which you can throw in this net in the bigger picture. But you have to classify all this. And you can see this number actually can go up and can go down, depending on the cases you have. At WHO, we just look at confirmed and probable cases. Possible, we just leave it at the back. So when I'm going to show you Ebola cases, that's what we do. But you have to keep the possible cases as well. As a part of the whole thing. And then I think your search could be prospective or could be retrospective, depending on the case and the information you have. So you can actually go back. So for example, classical example over here would be failure of endoscopy decontamination or sterile service or Legionella disease, whatever it is. So you really have to go back that this patient, where this was used. And this is what we call the look back exercise. And I think you must read, IPC, you must read one paper by Bill Rotala, published in 2010, asking if you have failure of decontamination, what sort of thing you should do. Okay, it's a very, very good paper. Prospective, these are the one people who are exposed. So you have now, this person was sitting norovirus in the middle of full-bedded bay. So now you're going to look at these patients, are they going to develop symptom or not? Yeah, so you've got prospective and retrospective. And then you have to create a line list and try to capture as much as information, but remember relevant. A patient with clostridium difficile, I'm not really interested that the patient has got headache, no, okay? So or hypertension, I'm not really interested. So do not collect information which is completely and utterly irrelevant. Ask any question which are relevant. And remember I said, always question yourself why you are asking that question, what you are going to get out of it. This I highly recommend if you don't have it. This is free tool available on the WHO, on the CDC website. It's called EpiInfo. It's got beautiful spreadsheet. It do all the graphs and the pie chart, and it's completely freely available. Try to utilize it. It takes out Excel spreadsheet, and it's completely free. So I think try to utilize something. Now, EpiInfo tool is not easy. So normally you have to have at least half a day or possibly a day training how to enter the data, how you get out of it. But it got a statistical tool and everything, and it's completely free. As the IPC team, I will request you to try to standardize the method. Okay, you try to standardize the method, how you're collecting the information. So every time when you're in Outbreak, everybody knows what information you want to collect and where we are collecting it, and then everybody train. Otherwise, what happens? Everybody have different ways of doing things. Okay, so I think this Epi-Info tool I think is quite useful. The second thing which is very important that you have to count the cases and exposure of the patient. You must actually draw a map of the unit. I cannot work ever in my life without drawing a map of the unit. I need to know where it is. So normally, as I told you yesterday, patients say, first patient on the left-hand side on the second bay. I count always the bay from the nursing station, but the nurse is actually counting bay from the other side, and there are 4 bays, for example. Then you have the wrong patient. And I've seen it wrong patient as well. So don't assume things. Once you have got a map, that will also help you to try to cohort patient. Remember, this is what we did yesterday. Now, if I were giving you information with no map, okay, which you even did not ask in the exercise. So can you see suddenly, yes, we are going to move these 2 patients to this 3-bedded bed. Yeah, you cohorted it, but if you have no map. So it is absolutely critical you have to have a map, because these patients are moving all the time, and these patients are actually discharged or died or not well. So you have to have this ongoing map, on a day-to-day basis. Second thing, I think it's very easy when you're actually going to senior management or possibly communication director say this is what's actually happening, and this happened with Pseudomonas outbreak. We have very clear picture with chief executive when we're meeting, what's actually happening and where the patients are moving and the whole dynamics. And everybody's very clear about it. And sometimes people actually work part-times and, I'm off in the afternoon and I'm good then go on holiday. I think there is handover. So once you've got all these maps available, things are documented, Second thing, practical point, just keep one file. Put everything into one file. Don't start to jot, this is my handbook and this is my handbook. No. Just create an Outbreak file. And everybody write into this, including microbiologists. All information has to be on the one side. So Martin may collect information on that particular patient on a single sheet of paper, and he can actually go back to the file, because the file may be actually taken by the IPC for investment. That's fine. But he can actually put his sheet with the date and time when it was communicated. You must actually consider an epidemic curve. This is a thing we don't do, okay, sometimes. To determine the source of outbreak, and then you describe the data, of course, in basically time, place, and person. Okay, so you have to actually construct that bit. And then remember, the patient can be discharged home in the community, so you have to have a follow-up of the community. That this patient has been exposed in 4-bedded bay, exposed to norovirus or E. coli 157 or whatever it is, and because the incubation period is about 3 days, and the patient was discharged only last night, if he comes to you with vomiting, most likely be norovirus. So you have to have this communication. Now, I can give you an example of lots of other infectious diseases, but I'm using norovirus as a surrogate marker, because this is what you understand inside out, okay? But you can actually apply the same thing to any infectious diseases, including tuberculosis. Because the other outbreak which happened of tuberculosis within our area, and which was linked to the pub. So when we actually look back this side, and we picked up 7 cases. Okay, but so there are lots of examples I can give you what sort of outbreak we have dealt with around here. So I think this is actually quite important, because the incubation period for tuberculosis is quite long, isn't it? But the norovirus only about 3 days. So you have to look at these follow-up of this exposed patient for that longer period of time. So this is the point source outbreak. I always have tendency to put patient and staff on the graph graph. So can you see S over here is the staff and P is our patient. So what do you think this epidemic curve shows? Can somebody work out? So what happened? You got index case coming in. You got all these new cases of staff going off along with the patient, and then we open the ward after 72 hours. Norovirus, isn't it? Classical norovirus. The patient came in, and this is a real case. Patient came in, vomited 3 o'clock in the morning, and the virus was spread virtually everywhere. Got phone call at 9 o'clock in the morning, went and visited the ward. By this time, the patient, everybody was exposed. We cannot do anything at all. So we put all the IPC measure. Now, once the staff are going off, it's norovirus, I can tell you, because it fits within incubation period. C. diff doesn't happen, isn't it? Yeah. So look at the incubation period. So when people actually say, this patient got tuberculosis and is exposed, you will not see the symptom, for quite a while, isn't it, depending on incubation period. Ebola, you have to actually follow for 21 days, yeah? So look at this period. Incubation period is really, really important. And we'll talk more about incubation period. What does it mean? Have you heard about quorum sensing? No? Okay. So we'll talk about this afternoon what is quorum sensing is, and you need to understand this incubation period really inside out. If you don't understand, you will never, ever be a good IPC. So incubation period is very important. This is what we describe continuous source outbreak. So point source, what actually happened? One person came in and then spread to the everybody else kind of thing. That's called the point source. Continuous source, something is actually happening, you know what I mean? And this over here, I can give example that this could be your endoscope decontamination, that somebody is not actually decontaminated properly in giving infections, or it could be Legionnaire disease, or it could be something else as well, So you cannot pin it down. And these are very, very difficult to control. So remember I've told you yesterday, don't go, when you go to the ward, have some question where this organism is coming from. So you need to know the microbiology, right? You need to know the source of infection, where it's coming from. You really need to know the incubation period. But you must have these hypotheses in your mind before you actually go into the ward. Otherwise, you're not going to get the information what you need. And I think what is hypothesis? So this is the English Oxford Dictionary, a supposition of the proposed explanation made on the basis of limited evidence as a starting point for further investigation. In IPC, in an outbreak investigation, an hypothesis, an educated guess, the source of outbreak. And remember, 2 days ago when we had this exercise, nobody was thinking, this mother, we have no MRSA for 18 months. This mother got MRSA, where it's coming from? Nobody thought of that. That's the first question I asked, where it's coming from, okay? So now I know when I went to norovirus outbreak, the patient vomited, I know this patient was symptomatic, you know what I mean? And then of course, we went back that why the patient got gastroenteritis and whole province was infected with norovirus. Why the person was not properly triaged, okay? That's what lesson we have learned, okay? He basically came with diarrhea and then he vomited, you know what I mean? And infected the whole ward. So there was failure of system in terms of going back, yeah? So then you have to go back, not the patient was admitted, and why this patient fall through the net. It could be genuine reason, but we exclude it as a part of learning lesson. So I think this is actually quite important that if you do not have this hypothesis in your head, then you will be run like a headless chicken, I can tell you. You have to actually work on where it's coming. Keep on asking where it's coming from till you get sleepless night, okay? You have to actually find out where it's coming from. You have to. So you have to consult public health agency. I think once you have this hypothesis, there is a case control and cohort study, which I do not actually believe that you have capability of doing it, including me as well, because you need to have involved epidemiologists. And most of the time it's Legionnaire disease and food poisoning, when the bigger outbreak. So then you have to look at the case control cohort study, and you need a public health physician for you to help you, because these are actually very complicated cases in terms of getting information, things like that. But these are mainly for the major outbreak. So you isolate patient, 7 point, yeah? And then offer appropriate treatment. So it could be antimicrobial agent. So why we give antimicrobial agent? Not for two reasons, isn't it? First, to make patient better. Or sometimes, remember, we talk of decolonization therapy in the babies to reduce the bioburden. And we can offer vaccination. So you've got this three front, the treatment of patient, it to reduce the symptoms. So say, for example, norovirus. If the patient is vomiting, please give them antiemetic. And the physician don't do that sometimes, okay? Because we don't want this patient to be vomited. Because how many viruses you need to cause infection? Only 10 micron virus. And 1 gram of feces contains about 1 billion virome. So 1 gram of feces will be enough to infect population of Northern Ireland 3, possibly 4 times. Okay, so this is so infectious, you know what I mean? So you have to take into consideration all these aspects. Then depending on the incubation period and the type of pathogen, you have to do the contact tracing, which include patient, staff, or visitor. Okay, so it could be any of these 3. So say, for example, here I'm going to change the example without telling norovirus, tuberculosis. If the child is admitted with tuberculosis, what you are going to do in terms of contact? You always have adult in the home. Simple, okay? So when I go for a child with TB, I look at, can you see what my hypothesis is? Where is the adult who infected this child? Yesterday, remember, same thing. So you have to understand, because children are not really very infectious with TB. Why they're not very infectious? Because they are tiny, they cannot cough with same vigorous, yeah? And then we are going to talk about the particle dynamics. So the thing which we have not covered is the basic concept in IPC, unfortunately, you know. So anyway, that's when I love to talk about it, you know, which is about a full day on how you transmit. If once you understand that, you know what I'm talking. And hopefully we'll talk something this afternoon. But you have to understand these inside out. So what is the exposure? So this is the reason they don't actually cough. The number of bacteria are not as much as the adult as well. So infective dose is low, right? And the forceful decimation is also low as well. Now, other thing, when you're investigating it, this is the classical example, and I think today is not it, but anyway, this is a classical example. Try to dig out, think beyond what you normally think. If you put all the IPC measures, and still you're not controlling it, what is wrong? Now, this is the example. Can you see this matrix, okay, which is completely perfect matrix, completely perfect. When you look at it, it's completely fine, no problem at all. Because we put all the measures for clustering difficile, and we simply cannot find where is the source, you know what I mean? And I had a sleepless night, where it's coming from, okay? So you start digging more and more, and this is what I did. When I lifted this one, which was completely perfectly normal sheet like this, opened it and found this underneath it. So then we start doing swabbing, and suddenly we found that approximately 70 to 80% matrices have got this thing. So the question is, why? They look okay. What are they doing to damage the mattress? So what they were using hypochlorite solution and soaking it for 5 minutes. And these materials are not made, okay, to take the brunt of the hypochlorite solution, which is toxic anyway. So this was all damaging the whole thing. And then you can see these are all the new matrices they have replaced. So what actually happened, the problem we were facing now was that these were the matrices which were supposed to be for the bed turnover. And I managed to actually get to hold of only 2 empty beds while the patient was in X-ray because the ward was full. So we have a complete plan to throw all these matrices out. And that's how we control the outbreak. Then I went into sluice room, which was absolutely filthy, you know what I mean? So we went through all issues, you know, on the C. diff outbreak. So keep on thinking, that's how we will see it, and you'll see, I will show you the figure in a minute. Now, this is another thing. I gave an example. You know, I come at 8 o'clock, you know what I mean? This looks clean. I mean, is it really clean? Now, how do you know it is clean, kind of thing? So you have to have some kind of audit mechanism. And in the evening, this was 8 o'clock, again, when there was nurse's handover. And I said, is it clean? He said, yes, clean. I said, how do you know? You just came in, like me. Okay, it's clean. And then I lifted it can you see it contains all the fecal material underneath it? So it's not clean. So remember, assumptions are actually quite dangerous, okay? So you don't want to assume things. There are assumption and there are assurance. Nurse was assuming it, I wanted assurance. So can you see there's a total mismatch between these two? And in IPC, you really need to know assurance. So if you go to court cases, and I've been to a lot, I'm telling you, and you go to court case, all these things, you are actually grilled onto these issues. If you don't document, nothing exists. Ignorance, it's not a defense. So please, as I've highlighted, update yourself. This is the area where I think IPCs, practitioners, both doctors and nurses are really very weak, worldwide, everywhere. They don't read, they don't keep update, you know what I mean? Once they are in their job, you know what I mean? And that's what it is. The amount of information which is coming on IPC, I'm telling you, I know very little with all the bits and pieces I have. I have to keep update myself. I read a lot, you know what I mean? It's really daunting task. There are so many journals and publications, and then you have to weed out what are the papers which are good quality, and you have to have that kind of thing. And we possibly have a session how to read a paper, okay, which is really very illuminating, I'm telling you. Most of the papers which are published in journals, right, some of them, they are paid publication. You pay $150 and they'll publish anything what you want, okay? So you have to actually weed those out. Because I did review for a few journals, and it's very interesting, So how you read your paper. So I think then we introduce this tape that is clean. Is it enough? Not really, because the thing I really need to know who cleaned it. I visited the ward 2 weeks later. There were 3 commodes, 2 were okay, and 1 was not okay. And then we went another one. So suddenly we found that one particular person was not really, whenever that person's name was there, that person was not doing the job properly. So we have to educate and we have to train them. And you have to tell them, okay? So just don't lambast all your cleaners, please, that you're not cleaning your commode properly. That's what happens, isn't it, if you don't know the name, that you're not cleaning properly. But all of you are okay. It's me who is the problem in terms of cleaning. So you need this information. Who cleaned it? And I'm telling you, in audit, you actually find the same thing. And this is what we're actually doing with blood culture audit. We want to find out not only the ward, but which ward and which area. Try to narrow it down as much as possible. That's why people ignore things. When you send out the email, please wash your hand. My hand hygiene complies with 100%. So some wards are good, some are bad, kind of thing. Try to narrow it down where the problem is, and we'll talk about this afternoon in about 5 minutes. So now you have got this sort of thing. Communication, absolutely critical to the patient and to their families as well in outbreaks. You have to remember that you must actually contact the GP and emergency department. So if you've got norovirus outbreak, your intelligence, the norovirus outbreak is coming, you don't wait for outbreak, no. And Ruth has been here, and we always have written letter to GP. Look, there's norovirus outbreak. If the patient have got sign and symptom of norovirus or suspect diarrhea, vomiting, please do not admit if the clinical condition is well, number 1. If the patient requires admission, don't send them to casualty. Okay, just put straight into a side ward. Find a side ward and put it straight into that. So triage is important. In terms of Ebola, the GP has to go to the patient. That's the triage. Because you don't want exposure to patient, you know what I mean? So it's the triage have a different level depending what you're doing. And A&E is also important, that if you've got patient with diarrhea, vomiting, you don't want them actually sitting in A&E and vomiting everywhere, infecting the whole lot, because this will be absolute nightmare for you. So I can tell you a story around here, I think, which is very interesting. We had a patient in psychiatry, and this patient, we would see about 3-4 samples of sputum, and this patient was just coughing all the time. Okay, the patient was coughing all the time, and she was just coming for the day care. And then what actually happened, that when after 4 courses of antibiotic therapy, when the patient did not get better, GP rang me. I said, if she's a psychiatric patient, alcohol intake, smoker, high risk of tuberculosis. And there you are, remember. When we looked at the slide, the TB was looking at me rather than me looking at the TB. So we have to look back exercise. 326 patients, we went back. Because she was sitting in the communal area, smoking and coughing. This is the olden days I'm talking, when you were not even born. So all these incidents, I can keep on quoting these incidents. So it was really, really nightmare. We have to go back to all these patients, you know what I mean? And some contact how long the contact was, how long you needed contact for TB, for contact tracing. Do you know that? Come on. Because we get a lot of queries from the aircraft. What 8 hours? What 8-hour exposure, okay? Anyway, so I think when you got bigger outbreak, like special care baby unit, anything, I always involve, Ruth knows it, we always involve the communication department. This is what's happening. So initially, it's the senior management level, and they will actually pass on to the communication director. But she needs to know, you know what I mean? Because sometimes you also have to tell them, and I had my finger burnt a lot of time. Sometimes the media actually bring straight to the ward what's happening, okay? And they will get information from the nurses. So you have to tell the nurses not to tell anything to anyone about this particular outbreak at all. So they're not part of the loop because it confuses the whole thing. So one day, I had an interview with a journalist in Lurgan Mail, some years ago, and he knew about the patient and the outbreak number of cases very well. So I said, where did you gather this information? Where he goes, there's one particular pub he highlighted. He goes to that particular one where all the nurses are coming over, and after a couple of drinks, they start chatting, and he pick up all the news stories from that Lurgan pub. Interesting, isn't it? So I think confidential issues there, and this is the reason I was shocked, honestly, that he has got exactly the same information what I have. So anyway, we had this conversation about that. So I think this is very important. Media management is really, really very crucial, Especially now, at that time, thank God we didn't have internet or Facebook or Twitter or any of these sort of things. But it was very contained. But now what happened, all these things are really, really go out. Screen person and environment. When you actually do that, this is a decision made in the outbreak meeting. Whom do you screen? You have to actually tell the microbiologist. Preparation, we talked about that, yeah? So you just don't send sample. And then if you got outbreak of food poisoning, you must involve environmental health officer. You must. This is very, very absolutely crucial. And then this is the last slide, just to tell that you must write an outbreak report. I personally prefer the outbreak report to be a couple of pages, 2.5 pages, not more than that, because this goes to the really, really high level, okay? So basically what you do, you just summarize the outbreak in a very succinct kind of way, that this is what happened, the event, what action you have taken, what action you are taking in the first report. That's what it is. This is what happened, this is what you do. Depending on the outbreak, you can have the first report, second report, and third report. Okay, you can have 3 reports if it goes long. If it's a short outbreak, you have first report, this is what happened, this is the measure we have taken, very high level, okay, this is what you have done. In the final report, you look at what happened, same thing, measure to have taken, because you may have taken additional measure from the first report, and then the final recommendation, how do you prevent it? So coming back to norovirus, when we identified that norovirus was going everywhere, the GP should have been informed, you know what I mean? And this is what we learned, there was triage failure, there was all this. So this is the lesson we have learned, isn't it, from that outbreak? So you have to put all these lessons learned, how to prevent it. And I think when you go to any public inquiry or any of these things, the question is, have you done your best? And second thing, have you really documented it? If I say, no, I've done that thing, but you have no documentation, I'm sorry. It does not actually get to the grind. So you just document everything what you've done, what you've said, whole bits and pieces. So this is quite important, I think. And as I've told you, that you have to give recommendation, what are the key, and you help them prioritize, because from that particular outbreak we were discussing yesterday, recommendation was to actually have an isolation ward, right? You know, the isolation ward, that was actually based on that recommendation. So I said, you have to have it, you know, because, you know, if the overseas is overflowing, we could have prevented it on day one kind of thing, you know what I mean, done something. And you'd send to the, not only senior management and to the clinician as well, but also the other appropriate person as well. And the report must be confidential. So this is quite important, okay? So it should not leak to the media. So I think with that, I just summarized those 10 points which I've highlighted. So you go through this per 10 point in your head for every outbreak, and you may stop at number 1. It's a pseudo outbreak and a story, or you keep on going, you know what I mean? So it's horses for courses, you know, depending what you're doing. Okay, thank you very much.